Carol McNeil, you have 5 minutes, I take it. Thanks.
Yeah, thank you, Chairman, and thank you, Mr. Reid, for coming in and for all of the work that you're doing. Just a couple of quick questions, please, on your statement. Just talking there about the median end-to-end turnaround time of being 2.2 days. Can you just confirm to me the complete turnaround time? Is that all contacts contacted or contacted and tested? Just what does that mean exactly?
Thank you, Deputy. The median end-to-end is for completion of test results, notification of test results, and contact of all those contacts. It doesn't include their testing. Their testing is then scheduled. They're offered a test immediately. We encourage them all to come forward straight for their test. So it's end-to-end to the contacts being contacted. Okay. I recall, I recall at an early part in this committee's work, significant, literature and other things being posted that it must be done within 72 hours. And I know it had been, much more when you started. So I just want to congratulate you on, getting to that point. And of course, there are outliers on both sides, but, really, it does need to be acknowledged how far the work has come. Can I just talk to you in particular about education and people going back to school this week and next week, and your engagement with the Department of Education, and what is going to happen if and when there is an outbreak in a school with a child, with a teacher? Can you talk me through what's going to happen? The Minister said last night that would become a public health matter. What happens? Yeah, thank you, Deputy, and thank you for comments. There has been a significant challenge to ramp up our resources to get to where we are. We want to continuously improve on testing and tracing, just to reassure the members of that. Thank you, Mr. Reid. Specifically, just in relation to, we've had significant engagement with the department, both at senior level, ministerial level and official levels. Our public health teams have been working collaboratively with officials over there for the past while. Specifically in relation to what happens when cases emerge and outbreaks, I'll pass in a moment just to my colleague, Dr. Colm Henry, who leads our public health teams, but just to make a couple of comments. Please, because I only have 5 minutes. Thank you. Okay, maybe if I just pass to Dr. Colm Henry, he'll bring you to the steps when an outbreak emerges.
Thank you, Deputy. Just the emerging evidence is that child-to-child transmission in school setting is relatively uncommon as we gain more evidence of the behaviour of this virus, particularly in educational settings as they open up in other countries. So what will happen, it's inevitable, that said, that there will be cases, that there will be suspect cases, and that there may even be outbreaks, and that's a price we must pay in order to open schools again with all the education and health and welfare benefits that brings to children. So what public health departments will do will apply the same principles as they do to outbreaks in any settings, and it's a risk assessment approach. So what they do in any outbreak setting is they will look at the individual characteristics of the school, they'll look at the rates of community transmission, they'll look at whether or not the number of cases in the school, number of serious illnesses that might emerge, which will be very uncommon and unusual in children, hospitalised cases, ITU, the interplay with community, the infrastructure of the school, the capability of the school to adhere to infection prevention and control measures, bearing in mind that some, for example, some special needs areas may require more intimate connection between people where distance is unavoidable. So it is not a tick box exercise. It's an individual assessment based on a set of principles by public health consultants who have the expertise and experience. Thank you.
Can I just ask you just specific points on what you've said, if you don't mind? So child-to-child transmission is very low, as you said. But what about what people will be concerned about is child-to-adult transmission, bringing it back into the home or bringing it back out to the community. Can you just talk to us about that?
Yes, so child-to-child transmission in educational settings, as evidence, as I said, is relatively low. And in household settings, the emerging evidence that children as a source of primary infection appears to be lower than that of adults. And when then you said about the community transmission rate, are you referring to the community transmission on a rate on a localised basis, on a county-by-county basis, or is it something that's a broader locality, or just clarify that as well? I'm talking generically that in terms of the primary source of transmission, it appears that in education household settings that children, particularly preschool children and primary school children, carry a lower risk than adults. And sorry, I just got distracted by the bell there. In relation to just the timing, clearly you've been working in relation to sporting groups and others from your statement where outbreaks have occurred. What can, if this happens in a school in the next number of weeks, how quickly will you be able to engage and respond? What's the nature of that, and how ready are you for that? Because obviously there's lots more schools and potential outbreaks than there has been in sporting situations or so on so far. Well, clearly one of the challenges we have is differentiating what may be COVID, which is unusual in children and presents in a different way, to non-COVID and much more common illness in children in education settings, upper respiratory symptoms and other cough or respiratory symptoms. We have developed an algorithm working with experts in paediatrics, GP, primary care, public health. This algorithm and the pathway was discussed with GPs in a webinar 2 nights ago, almost 2,000 GPs. And this describes the series of actions that will be taken once a suspect case emerges in a school. And as was highlighted with my colleague Dr. Mary Favier the other night, it balances the needs for continuity in education with the need to identify cases where they emerge with children. So, for example, children with sniffles or mild upper respiratory tract symptoms do not warrant testing and can continue to attend at school, while those with more specific symptoms, such as cough, respiratory symptoms, loss of taste or loss of smell, it does merit isolation and testing. And this algorithm is for GPs and will be communicated clearly to principals in schools to enable them to take the right and appropriate set of actions should there be a suspect case in school.
Thank you, Dr. Henry. Thank you, Chair.
Thank you very much, Dr.